Okay, good evening and welcome to the Fall 2020 University of Rhode Island College of Nursing Distinguished Lecture Series. My name is Barbara Wolf and I'm the Dean of the URI College of Nursing. And before we get started with our featured speaker, who we are very excited to hear, we have a bit of housekeeping. First, please select the speaker view. That's something that is up in the right-hand corner of your screen to give you the best view of tonight's presentation. Also, this nursing continuing professional development activity has been approved by the Northeast Multi-State Division, an accredited approver of the American Nurses Credentialing Center's Commission on Accreditation for 1.5 contact hours. No individual in a position to control the content for this activity has any relevant financial relationship to declare. You will receive an email at the address that you used to register for this event with more information on how to obtain your CE credit. Now, on to the main event. We are thrilled to welcome tonight an internationally recognized public health expert, Dr. Nancy Devanter, who will be speaking about a timely and critically important topic, nurses on the front line of this pandemic. Her presentation is titled COVID-19 Nurses' Experience in 4 New York City hospitals, in their own words. Dr. Devanter is a professor at the New York University Rory Meyers College of Nursing. She's also the Deputy Director of the NYU Meyers WHO Collaborating Center. For decades, she has conducted behavioral intervention research, integrating a community-based participatory research approach into the development of testing a theory-driven intervention to promote health and reduce disease in populations with significant disparities. This includes HIV, STDs, and tobacco-related issues. She's been involved with numerous interdisciplinary collaborative studies with the NYU Schools of Medicine, Dentistry, and Public Health. She received her PhD from Columbia University School of Public Health, an MPH from Harvard School of Public Health, a master's in education from Boston University, a BS from Boston University School of Education, and an RN from St. Agnes Hospital School of Nursing in Baltimore, Maryland. She is a renowned researcher. She has approximately 100 scientific publications, incredibly successful at federal and foundation funding. She herself, as the principal investigator, has had funding over $35 million for support of her research. And then if you add those studies where she's been a co-investigator, that's another $48 million. So indeed an impressive trajectory. She's a fellow in the American Academy of Nursing, as well as a fellow in the New York Academy of Medicine. She received a commendation from the Office of the Secretary for the U.S. Department of Health and Human Services for her contributions. It is indeed my pleasure to welcome Dr. Devanter to URI. Welcome.
Thank you. Thank you, Dean Wolf, and thank you also, Associate Dean Hutchinson, for inviting me to this really exciting event. When I heard the title, Nurses on the Forefront of Change, I thought, that's a place where I want to be. That's really an exciting kind of concept. So today I'm going to be talking about a study that we've just done. Actually, we started in March of this year when COVID was in its full flower in New York City. And the analysis that I've done on a particular aspect of that study is what I'm going to be talking about. This was really an unprecedented event in New York. I've been there for a lot of disasters over the years, but this one has been a really, really tough one, especially on nurses. One of the things that I thought about, and I was speaking with Dean Wolf about earlier, is that I'm not sure how much experience you as the audience have actually had directly with COVID-19. And I just wanted to alert you that these are these quotes from the nurses that have worked in this, and we have over almost 600 of them, are sometimes really tough. They're hard things that they've been through. They're sad. They've been frightened. These are This is a pandemic is different than another kind of disaster in the sense that both the nurse herself feels vulnerable as well as their families. So I just wanted to give you a heads up. I thought it would be helpful before we went into the findings from the study to show you a short video that was actually done this spring in another hospital in New York, which describes what the nurse's experience was. But before I get to that, I'm going to quickly just give you a little bit about my background and why I work in disasters. I didn't actually set out to have a career in disasters, but after spending some time in Boston, and I was in a couple of different programs, including my MPH program, I moved to New York in the middle of the 80s and got there just in time for the real catastrophe of AIDS. I, through one of my professors at Harvard, ended up taking a job at the New York Blood Center, which was one of the first places in the country that they were doing testing for HIV. No one, real people, regular people, were not being tested. These were just blood donors, and it was really to protect the blood supply that was happening. And we knew so little about what it was. All we knew was that people were dying. And we knew that we had to test the blood system in order to know and not be transmitting the virus to other people. So the blood donors that ended up being the center of my job were basically, our job was to tell them that they were HIV positive and to counsel them about what to do to protect themselves and to protect other people. In about a 1.5 year period, I should pause and just say, I immediately knew I was in trouble, and I hired a team of mental health nurses because there was no other way we're going to be telling these people this and trying to provide support for them without a really good team. But in a period of a 1.5 years, we notified over 1,800 people that they were positive for HIV at a time when no one else was really being notified. So it was really kind of a breakthrough kind of model. We created a model which we published, and I was forever grateful for the people that I was able to hire. So that was my first disaster. It was a pandemic. I don't think I even thought about it at the time as a pandemic. And not very, very long after that, actually it was long, it was maybe 10 years later, was when 9/11 happened. And that was New York's trauma as well. It was quite unique to the city. We were prepared, the hospitals were very clearly prepared to take care of the survivors. Unfortunately, there weren't any survivors. And that left me and a whole lot of other health professionals feeling pretty helpless about, what could we do that would make a difference. And fortunately, I had been working very closely with the New York City Department of Health for a number of years on HIV prevention. And it occurred to me that it would be really, really interesting to know what the department's role was in responding to 9/11. What happened to them? What did they see? What did they encounter? So together with a couple of public health historians, we conducted an oral history of what occurred in the New York City Health Department. What were the challenges? What were the things that went well? What were the things that they hadn't anticipated? So I was actually presenting that at a conference a few years later, not long after Hurricane Katrina, and there was someone in the audience from the Robert Wood Johnson Foundation who said, gee, we think that would be a really good thing to do in Louisiana, Mississippi, and New Orleans. So I was on to my third disaster by that time. So in the meantime, I've done a lot of other things. I don't only do disaster work, but we were very fortunate, or unfortunate, I guess, for the hospital. In 2012, Hurricane Sandy hit New York City, and 3 hospitals that were very near to the river ended up being actually totally shut down, and the patients all had to be transferred out. And because of our working relationship with the medical center, which is part of NYU, we were able to do a study with the nurses and their response. It was a little bit of a different situation, it was a very different situation actually, because these hospitals closed and the nurses from them were reassigned to other hospitals where they'd never worked. They weren't licensed to work. They had very different administrative systems. And so the trauma for them was the 3 months after the actual initial disaster. So because we had a good working relationship there, when COVID came along, it made it a lot easier for us to get access to the nursing population. And by that time, the whole NYU system had grown to be 4 hospitals, not just 1 hospital. So we had very different kinds of settings in which to conduct this study. So that's what I'm going to be talking about today. And before we get to it, I think we're set up to do the video. But I'd like to warn you that this is really tough stuff, and it's graphic. And so I think you should have your eyes wide open and know that these are very difficult issues for nurses to be dealing with. So are we set for the video? Okay. I apologize, they're kind of noisy because it's New York. Are we done? Okay. Well, as I said before we started to look at the video, there's some tough stuff to watch in there. And I wanted you to see it because I wanted to let you know that the study that I'm presenting here will have quotes from nurses about what their experience is. And as is our tradition in qualitative research, we don't clean up the grammar and we don't clean up the punctuation. And so if you see misspellings and things look a little fuzzy, that's the nature of doing qualitative work. So I think this video was a good preparation for that. So I think we can move on to the slideshow now. And as Dean Wolf said, the study is actually called the COVID-19 RN study. It doesn't get much simpler than that for a title. And you can go on to the next slide. The way we ended up getting this information, here are the investigators. Let me just introduce them. I'm the principal investigator. My colleague, Dr. Victoria Ravis, is a social psychologist. And she and I have done multiple studies together. This is actually the same team, or mostly the same team of us that did the Sandy study. Christine Kovner, who's well known for her research on nursing workforce. Laura Jean Ridge is actually a postdoc. She graduated from our program last spring, and she's a postdoc at the University of Michigan, where unfortunately she can't be because they have virtual classes. So she's with us, and we're very lucky to get her, and she's getting a good experience. Kimberly Glassman is actually new to our faculty, relatively new, and Kim, it was previously, actually for the last 20 years, she was the vice president for nursing at Langone Health Center, and she is the reason we were able to do the Sandy study, and she's been invaluable in helping us understand the nursing workforce at these hospitals. Gary Yu is a biostatistician who's actually working as a volunteer. We had a small amount of funding from Langone and from the College of Nursing. We didn't want to take the time to put in a formal NIH proposal because we felt like we needed to get in the field as fast as possible. So that's our team. Next slide. Just a little refresher here on what these terms mean, because we kind of sling them around these days. So an epidemic is a public health term that means a disease that affects a large number of people within a community is going on. A pandemic is an epidemic that's spread over multiple countries or continents. And that's what we had in AIDS, and that's what we have in COVID. An outbreak is a greater than anticipated increase in the number of cases in a given area. It can be a single case in a new area, or it can be too many cases in a specific area. If it's not quickly controlled, an outbreak can become an epidemic, and it can become a pandemic. So that's the terminology we're using. So we're on the study setting. Did we just skip a slide? It looked to me like we skipped a slide, or did we go too far ahead?
We went back.
You're back now. You went back, okay. So the study was conducted in 4 greater New York City hospitals that included a large comprehensive medical center, 1 urban community hospital, a suburban community hospital, and an urban specialty hospital that actually was turned into a 100% COVID hospital. It had been an orthopedic hospital. So those were the 4 different hospitals that we were able to recruit from. I think we skipped, yeah, the aims, that's where we want to be. All right, so the study aims overall were to quantitatively explore the role of disaster-related factors, things like how much the nurses have the pre-disaster education and training, prior disaster experience, and how that impacts on their psychosocial functioning in the midst of the disaster. We also wanted to explore the role of resilience in nurses' response to the COVID-19 pandemic. I will describe this theory, resilience theory, a little bit further in a future slide, so you'll know more what that's about. But it's commonly used in the area of disaster response. And then finally, we wanted to qualitatively explore the interpersonal, institutional, and team-related factors that influence the response to the COVID-19 pandemic, the response of nurses to it. So those were our overarching aims. The theoretical framework, resilience theory, resilience is essentially the ability to return following a stressful event to a prior level of psychological functioning. Factors that facilitate resilience include things like personal characteristics, which you might suspect, self-efficacy, self-esteem, adaptability, and those are considered assets that the individual brings to the situation. But resilience is also impacted by the social environment, what kinds of protective factors are there. So strong social and institutional support, and those are considered external resources. So those were the kinds of constructs we were looking for in analyzing this data. So you can go to the next slide. So I already mentioned Dr. Glassman was extremely helpful in getting us connected to a brand new vice president for nursing, but also with the nursing leaders from the other hospitals who she knew and had worked with, and so that was extremely helpful. So what we did, which is very similar to what we did in Hurricane Sandy, is we developed a nursing advisory committee. Dr. Glassman and the director of nursing at Langone helped us identify people that would be appropriate for advising us. There were representatives from all the 4 hospitals. And what we asked them to do essentially was, we really sort of took the Sandy survey because we had measured a lot of things we thought were important, like depression, anxiety, stress, PTSD, those kinds of things. And so we kind of took that because they'd already developed it. But we wanted other people to look at it and say, does this make sense, given your setting, given what your nurses are experienced, does this work? Are these the right questions? And they were extremely helpful both in validating what we should include, but also telling us things that we didn't have in there that we needed to expand on. So they were, I would never do a study without an advisory committee like this. It's extremely important. So we can go to the next slide. So the quantitative sample, so all nurses that worked in the 4 New York City hospitals that were part of this hospital system that were working, employed on May 5th, 2020, received an initial email asking them if they would like to participate in the study. 2 additional emails were sent over the next 30 days. We sort of spaced them. We worked around the holidays and things like that to make sure that we were getting maximum coverage as reminders. I've already described the hospital, so you can skip that. So we collected data starting May 27th, so right before Memorial Day, up through July 11th, just after the 4th of July. Assuming that people that maybe had a little time off might have more interest in filling out this this is an anonymous electronic survey. And it was sent out to 7,291 individuals. And of those, 2,945 responded, which is a response rate of 35%. For surveys of nursing, that's a very respectable response rate. Nurses are often busy people. They don't necessarily stop to fill out surveys of this kind. So we were very, very pleased with the response rate. So next slide. So the qualitative study sample, we didn't even realize we were doing a qualitative study, to tell you the truth. At the end of the quantitative study, participants were asked an open-ended question. Do you have any concluding comments you would like to share on how your work life changed since COVID-19? We got 591 lengthy statements from these people. They wrote it in, typed it in, whatever. This, again, it's still anonymous. But we were amazed. When we printed it out, it was 33 pages long in a very small font, which is a ton of information. So actually, in retrospect, I feel very good that we included a question like this because they did have a lot to say, and I think it was important for them to have that opening, to be able to say that. So, but one of the things I was concerned about is, are the people that responded and wrote these comments going to be different than the people that didn't write them? And so we did analyses looking at, were they different in any of the following? Were they demographically different? Were they older? Were they younger? Did they have children? Did they not have children? We also looked at the age of the children. What was the hospital setting, type of unit they were in, reported stress in caring. We had some very significant questions in there about how stressed they might have felt in caring for COVID patients. We also looked at depression, anxiety, and PTSD, and there were no differences between those who responded and those that didn't. And I'm not quite sure what to make of that. It may be just that we caught some people when they had enough extra time, or that the questions in the survey generated thoughts for some people, and that they had the time to sit there and keep typing. So I don't think we'll ever know, but this is an extraordinary rich database that we uncovered here. So that's the qualitative study sample. We can go on to the next slide. So our methodology in approaching this, it was a little overwhelming. The first thing we did was I just sat down and I read all 591 of them, and started to try to think, well, what are some of the things that are coming up? And I also did keep in mind the resilience theory framework. What are some of these characteristics that might be showing up in this data that relate to that framework? Then there were two other qualitative researchers, Dr. Ravis, who's done a great deal of qualitative work, and Laura Ridge, our PhD postdoc, who actually had done a qualitative dissertation. And so they then read through them, and we began, the three of us together, to develop a code book. It wasn't a code book until it was entirely done. It was a work in progress. But and so we included in that the constructs from the resilience theory. So what we were doing was both an inductive as well as a deductive approach to analyzing the data. The deductive being the use of a theory, and the inductive just seeing what bubbled up, from the data itself. So the themes were identified through an iterative process. Two qualitative researchers used both of these approaches, and essentially we were testing each other to make sure we were coding things the same. So the results, as I already said to you, are presented in exact quotations from the participants. Oh, I think we can move on to the first. Okay, you can skip by this slide. This was an introductory slide to the video you've already seen. So I wanted one quote that kind of captured a lot of the things that came up, and this was one I thought that was had a lot of information in it and was kind of an overview quote. So this participant said, "It was extremely difficult when all this began in our hospital. I've never in my life or career seen anything to this extent. This is a time I will never forget. I tried my hardest, and I hope the patients and families we dealt with have found peace. I hope the ones that survived live long, wonderful lives. The only thing that came from this was teamwork. We all pulled together, and we were there for each other on the front lines every day, working tirelessly. I thank my fellow nurses and nurse managers and travel nurses, and I'll tell you more about travel nurses shortly, for coming in and helping us. I only hope this continues to get better, because I don't know if I can handle it again, but I will if I have to." So we can, next slide. So the challenges in coding all of this data that we came up that seem to be the themes emerging. The first one that we identified was a perceived insufficient institutional support. And that's reflected in a lot of things that you'll see. I think in general, there was an overwhelming sense that nobody was ready for this. And I don't think anybody was ready for it in any other hospital. I don't think this is unique to this situation. It was like a tidal wave. And so that's part of why people, I think, have a lot to say about not feeling they got the support because the planning wasn't there. I think another part of it, and you'll see this in the data, was, and this was very complicated because it meant they were at risk themselves, was the lack of the PPE, the protective equipment to keep them safe and hopefully protect their families as well. So the challenges were insufficient institutional support, also home and work life challenges, and there are a whole variety of them. We'll go through the examples, but you can imagine if you're somebody who's working in a situation like they were, going home and interacting with family, especially if you have older family members or you have children and you're worried about infecting other people, that's really, really hard. And also they're working very, very long hours, multiple shifts at times. And then there were interpersonal challenges to working in COVID, just fear for yourself, fear that you can't do this work, a whole lot of things like that you're over your head. The facilitators that we identified, interesting, reflect some of the challenges. For some people, they were able to identify the institutional support that they did feel was there and that helped them get through. And then other facilitators were more like the assets I mentioned earlier in the resilience theory. What is it about the unique individual, their own sense of self, their self-efficacy, their conviction that they can handle anything? Those are things that came to play. So we can move on to the next slide. Oh, okay, sorry, we're there. So the other things that came out that we thought were important to look at were post-pandemic needs. Over and over and over again, people said, we have to talk about this. We have been through hell, and we really need to process and identify what are the things that we really need to be prepared for the next time, for the next pandemic. Another post-pandemic need was to develop a better process for disaster preparation that includes the nurses themselves in the process of decision making. What we heard over and over and over again is that they were getting things thrown at them that they hadn't any choice about. They were reassigned to units that were and put in situations where they really felt way over their heads, and I think it felt disrespectful to them to not be a part of that process. The other thing we discovered, and actually I was surprised that there wasn't a whole lot of this, potential long-term outcomes. I think we only had 3 or 4 people that actually talked about the fact that they really did not think they wanted to continue in nursing or that they were considering a change. And for some of them, it was a change of institution, not necessarily leaving nursing. But when I think about reading 591 responses, and there were only a handful of people that said, maybe I don't want to do this anymore, I thought that was quite remarkable. So, next slide. Okay, so here are some examples of what their specific remarks were about these perceived insufficient institutional support. So one of the participants said, I think the whole hospital wasn't prepared enough, and regulations kept changing too often. Everyone was confused. We were not being trained properly. We were constantly being exposed to COVID patients still because they weren't screening properly. Another respondent said, work life was horrible. Patients suffered a lot. There were no supplies. There wasn't enough staff. Nurses felt they could rely on no one. And these are a few more, so I'll just go through them. Going slowly with CDC's inadequate and slow response was a poor decision on the hospital's part. If you remember at the beginning, there was testing issues with CDC. They didn't have the proper test, or they were getting a lot of mixed results. New York got on that very fast, and actually New York opened up its own labs and did its own testing very, very early on, which I think was an enormous help, but in the beginning it was quite confusing. Initially, the hospital thought it would be possible to separate the triage pathway with COVID versus non-COVID suspected cases. When brought up that there's literature that shows this actually doesn't work, the hospital wasn't interested in hearing from a staff RN. Another person said, I think that our hospital, as well as most of the nation, was wildly unprepared for the pandemic. I hope that history does not repeat itself in the future. And last, the pandemic opened my eyes to how unprepared the hospital was, but I'm grateful for the level of teamwork and our ability to come together during extreme difficult times. Next slide. So the second challenge, and I can't see some of this. I think this is PPT, lack of personal support and appreciation from leadership. Hold on, I'm gonna have to look here because it's covered up there in the challenge 2. Okay, perceived, no, okay. Insufficient communication and transparency about the pandemic, lack of personal support and appreciation from leadership. So this, and this sums it up very nicely. While I understand the need to make quick decisions without a lot of time to disseminate information at the beginning of this crisis, I think some later decisions regarding plans for unit COVID designation, staff deployment, could have been much better planned in advance, been more transparent in the plans to other leaders, and thereby communicated much better to staff. The majority of feedback from nursing staff is that they feel like pawns or disposable chess pieces to leadership, and that's unacceptable. They should be provided with better insight and better support to avoid that. I think we can go to the next slide. All right. So this is about the availability of personal protective equipment, which there was no single factor that had more comments than this. This was so bad. I will never take for granted the importance of having enough personal protective equipment. It is disturbing having to reuse N95 masks. This should not happen. I don't think this hospital was amply prepared to take on this challenge of COVID-19. There wasn't enough PPE for us nurses to adequately change them daily, and we were left to reuse the same mask and gown and face shields for weeks at a time. And then this I mentioned earlier, the lack of inclusion of nurses in decision-making about staffing and reassignment. This participant said, I hadn't worked on an inpatient med-surg unit for about 8 years, yet our nursing leadership redeployed myself and one other coworker to an inpatient COVID unit. The month that I worked on this surge unit caused me anxiety and physiological symptoms like insomnia, loss of appetite, and chest tightness. Thankfully, I made an effort to utilize the mental health resources offered by the institution, engaged and still participating in telemental health visits, and was started on an anxiolytic medication. I'm not sure I'm saying that right. The main input I would like to offer is that leadership should be more transparent with frontline workers about emergency plans and redeployment in the future. Involve us in the process so that we have a sense of agency in what will be happening to us. I definitely feel like the mental health symptoms I suffered could have been significantly reduced if there was more frequent, open, honest communication with leadership and those in charge of reassigning staff to assist during this emergency period. And this came up over and over again. There were apparently a number of different plans that different managers had about how they want to thank their staff, but there was no consistency, and there were different rules for different hospitals, and so this sort of was like, I don't know, just adding insult to injury, I guess. So this person described it this way: I'm forever grateful for the opportunity to care for those who are in need of my care, as I have always felt. I'm blessed to have not caused my family harm. I just hope that this organization will show their appreciation for the sacrifices made by nurses and healthcare workers without so many stipulations, and reward everyone equally. So then this next area, I can't see this very well, but this is home work life, and it's really about the fears of infecting your family. So this participant said, coming home, leaving bags in hallway, and running to shower, disinfecting everything I touched, trying to keep distance from my family in a small apartment, and always thinking, what will be tomorrow? When will it be over? Every day hear from one friend, another friend, his or her family member, neighbor, relative, friend died. It was challenging emotionally. My coworker, close friend, got sick with COVID, told me that she was writing a will and contacted a lawyer. It was scary. Now we're back in ORs. There are no more COVID patients at the hospital, and this brings a sigh of relief. Another challenge was the need to separate from family. Some people literally stayed in hotels that the hospital provided for them, or they just physically separated themselves from their families in other ways. So one participant said, the hardest part has been not being able to see my grandson or my mom since mid-March. I became COVID positive at the end of April. It's a very scary, lonely illness. I was very sick and afraid of dying. I'm still not recovered. Another participant said, it was quite a lonely time, being isolated and sacrificing, being away from my family for almost 2 months. I'm thankful to have a secure job and pay all my bills during this uncertain time. And finally, since COVID, I have not been able to stay or see my family since my dad has a compromised immune system. This has severely impacted my life with my family. This is about feeling you don't have the skills for the assignment that you've been given by administration. So this participant said, due to COVID-19, I was asked to take care of patient population that I never took care of before. I know there are other nurses who are experienced and can be provided as a resource. I felt anxious and worried when taking care of these patients, afraid that I do not have the competency to care for those patients and end up causing harm to a patient, not being able to pick up early signs of clinical changes among those patients. Another is a sense of helplessness, which I think a lot of people felt with people that were terminally ill with COVID. It feels terrible not to be able to really help most of these COVID patients. We oxygenate and monitor them, and they either live or they die. It's like being a farmer in a drought. And then this, I can't see these. Oh, this is just essentially the effect on individuals about the symptoms they experience from being through this. I need to be on medication for anxiety and depression. Another person said, I was transferred for 2 months to the COVID ICU, and the first month, the end of March to April, was very traumatic, depressing, and lonely. It was the hardest experience of my nursing career so far. I struggled to properly take care of 2 very sick ventilated patients at the same time. As someone who's single and living far away from my family, I was on my own to cope with my new work situation. I was transferred to a unit where I did not know any nurses from beforehand, and even though everyone was very nice and helpful, it was a very lonely experience. I did not have any close nurse friends to help me cope. I did not have anyone at home to help me cope. My mental health took a heavy toll and I struggled. And another person said, everyone did an excellent job working together with the illness being scary and unknown. I truly believe I have PTSD from it and can cry at the drop of a hat when thinking about COVID-19. This is another fear, but I can't see it. I'm sorry. Let me just look in my notes here. I think this is actually the same thing. During the peak of the pandemic, I went into work extremely nervous, anxious, and terrified, wondering what assignment I would get and how much stress I'd be in. I was on edge about when and how I would contract the virus, and was disappointed that we did not get PPE we needed and deserved. I cried several times due to my work-related stress and seeing the conditions my patients were in. I cried seeing someone my age die from COVID. I cried from being separated from my newborn niece. It was depressing having to deal with all that at work and then coming home, feeling trapped due to the lockdown. I felt like there was no air to breathe and no room to think. So these are some of the symptoms that people experience, and I'll go through this fairly quickly so we can get to some of the more positive stuff. There is some positive stuff, I promise. So this participant said, I have PTSD. This experience has given me extreme anxiety, and I continue to be extremely emotional. I have trouble sleeping, nightmares. I reach out to the mental health that was provided, and I feel it didn't do any good. Another person said, it's been very difficult to adjust to my home life. I have difficulty sleeping. I am, however, surrounded by family, which makes it a bit easier to cope. And this was actually sort of existential comment that I thought was really summarized what a lot of people were saying. There were shifts when all we saw were patients being transported to the morgue and getting ready for more. There were weeks when all I would do is cry getting home from work, cry in the shower, cry randomly. It took a toll on my husband and affected his mood as well. It changed who I was. While I'm still working with COVID patients and have more time and resources, I know I've not been able to process what happened. It's all a blur, most of which I choose to block out. I think in order to help nurses cope, it's imperative to ask us for input more in these times and give us more surveys. So I thought that was good. And then here we have the facilitators. These are the things that people found that helped them through. So the first is actually the flip side of the first one on the other side, institutional support. There were people that found institutional support and felt that, and it helped them. Institution provided commitment to excellence, support, and sufficient resources to do the job. Another participant said, I'm proud to work at this hospital. I feel the institution for the most part has handled the situation well. It's just very stressful. Another person said, I feel that how this hospital has handled the pandemic made me feel very confident in our ability to handle whatever pandemic or future crisis will hold. We hired numerous capable travelers and retrained staff to take on different roles, which they were very willing to step up to the plate in uncertain times. Also, the ongoing communication and support we received from collaborating hospitals was very encouraging. It all made me feel very proud to work here. So travel nurses, I will just interject here. This is actually a profession. I never knew it was a profession, but there are people that do that, and they're basically in kind of on-call mentality wherever there are disasters, whether it's hurricanes or any kind of natural disaster or something like COVID. They volunteer and they come. And because most of everything that they do is very disaster driven, so they have a confidence and they've worked in very difficult in difficult situations. So I think they were extremely important, and I think they gave a shot in the arm to people who were being thrust into roles that they don't typically have, or practice in. So availability of counseling was another facilitator for people. My hospital did offer counseling services, and I had my own therapist as well. But it was still a very hard month for me. Thankfully, May was a better month with more staff, better patient ratios, and I had gotten to know my new coworkers better. I think this is support. Oh, this is support from other people. Again, I apologize, I can't see the top. But essentially, this person said, COVID made me appreciate how much it means to be physically near my family, friends, and loved ones. I think what I found most unbearable during the surge was being alone at the end of the day. I couldn't hug my mom, get a kiss from my boyfriend, or cuddle my newborn niece, or have a hangout with my girlfriends. It made all of those small interactions so significant, so much more important to me now. I've also never appreciated my fellow nurses more. I found comfort in being with them. Because I couldn't be close to my family at home, they became my family. I found solace in talking with my colleagues, sharing the good and the bad. It made this whole ordeal a little more bearable because I knew I wasn't the only one feeling lost and alone with it all. Another participant said, we were there. We were there for the first death of the COVID positive patient. It was the first confirmed case of COVID patient and the first to die. We couldn't fix her. We just watched the virus progress to a point where this person couldn't be saved. We did not know how to manage this patient, and the disease progression was unknown. But we did know one thing: she died because we did not know how to save this patient. All the warning signs were there, the impending signs that they were going to crash. The best RN we had on the unit was assigned to this person, but even we can only do so much as we frantically compress the chest. This death only confirms two things. We did what we could to help this person, but this is a novel disease, and RNs are there for each other when we need each other. Next slide. Teamwork was a huge theme. Almost everybody mentioned teamwork at some point in time, which is very reassuring. I think this pandemic was an eye-opener for physicians and advanced practitioners to come together and work more closely with RNs and appreciate the work we do. It will make the healthcare system stronger in the end. And this is the travel nurses. It was great having travel nurses to take some of the burden off of our shoulders. Once they came in, the nurse-to-patient ratio definitely made working during this crazy time much less stressful and was deeply appreciated. The travel nurses were a godsend. I only wish they could have come earlier in turning our floor into full COVID. There were emails constantly about studies being done, but the majority of caring from patients was learned from fellow nurses who had different info. That was something I heard over and over again. People were getting a lot of informational emails, and what they really needed was a pat on the back. So all that stuff that was getting, coming to them was frustrating to them. So I think we're almost through here. There we are. The gratitude of patients. That was something that people really appreciated. There was so much gratitude from patients and their families for the work that we did, for showing up to work and doing what we were supposed to do. It was incredibly moving. This experience has changed us forever. We will not be the same. And the community appreciation in New York was a feature of COVID. I just want to be thankful for my team and the generous donations from the public in this pandemic period. Lots of food sent in by restaurants, sent in by people. Without this kind of support, our jobs at bedside would have been tougher. Thank you for all. And this is about the profession of nursing. And I was happy to see this. I have a renewed sense of pride and purpose in the nursing profession, as I know my skills are still strong and relevant. Another participant said, I've never been prouder to be part of a profession that showed up every day and risked their own well-being and that of their loved ones to care for the people in need. I strongly feel that every great hospital is built on the back of their nursing staff. This hospital is most fortunate to have a nursing staff such as ours. Another person said, I have learned the real value of being a nurse. I felt competent in MCI. We have patients lining the hallways and realized constant across the room observation. It's been easier to work with one or no visitors at the bedside. I hope the appreciation for the profession remains. These patients were sick and scared, and it was up to the nurse to provide top care. And finally, I love what I do, and I was happy to be able to help in an ICU setting. I do not regret any part of this experience. I think that's, this is the last slide, I think. I appreciate the survey, and I hope that it helps support our profession and also our patients. Although I did not participate in the evacuation patients during Hurricane Sandy, I worked at this hospital throughout that experience. The hospital knows how to respond to disaster. That being said, these types of disasters take a toll on us, our staff, colleagues, and patients. We need to look to the next phase of care for nurses and all hospital staff as the trauma of the situation is just starting to set in. And finally, I think the effects of this pandemic will last a lot longer on the mental and emotional health of nurses, far longer than we expect. We have been put through the absolute worst and continue to do so. I've already covered this in the previous slide, so you can go on from here. And then nurses leaving the profession, we already covered too. So there are a few people that did say that. And then this is just a comment about comparing Sandy as an experience that people have been through to COVID. I did not evacuate the night of Sandy, but I was here the night before and the immediate days after. Those were stressful times as well. But this coming to work and risking your life at every shift is different, and having a family and worrying about bringing it home is nothing like anybody could ever imagine. Fortunately, we were not in the thick of the virus every single shift, all shifts long being in peds, but the potential was still there, and we did assist the peds units, which were turned into adult ICUs, as well as transporting positive and ruling out COVID ped patients. And we've covered some of this too. I think this is, for some reason, redundant. I'm not sure why. This is, next slide. Next slide. Next slide. I think we're repeating. These are repeating now. So can you clue in the final video? It's a short one. So this is a little video of the nightly ritual, the 7 p.m. nightly ritual in New York City, for thanking all of the healthcare workers. So I asked the audience to bear with me for a few minutes. I wanted to actually be able to hear from you a couple of different things. One is, does any of this, what we've been talking about, resonate with you? Have you ever had disaster-related experiences? Have you ever had concerns for your own safety and for that of your family? So I'd kind of like to just hear from you about that. And then I'd like to ask you also a little bit more about how prepared you feel to if you were to face some of the challenges that these nurses have faced. And I realize I can't hear, so you're going to have to read me what you're getting. Is that right? Is that how that works? Well,
We have some questions from the audience that were already pre-populated. I think we might have to go to them.
well, if you want, I can answer those questions first.
All right, we have a few questions from the audience.
Okay.
Are there plans in place to do follow-up with these nurses?
Well, I was asking myself that this week because I think that we're headed back up, unfortunately. It's not going to be as bad as it was in the spring, but we certainly do have more cases. And I personally would like to do a follow-up study. And because we were so successful in being able to access and had such a quick response, I feel like it's really worth a shot. I mean, we don't have a big, pot of money to do it, but it doesn't cost us anything to send out an email and repeat the survey that we did or add some additional questions to it. So that's my response. I don't have all the power and control over it, but that's my response. I would like to get back in there as soon as possible.
Also, was there any input about what the nurses might do differently given the same circumstances?
Well, most of their suggestions for doing things differently had to do with being a part of the process. They really felt that things would have gone much smoother had they been a part of the planning process. And I think back to that time, and I don't think we all knew what we were walking into here. I mean, it just hit so fast. I actually was in New York, and I was getting nervous about getting on subways and things like that. Didn't know if I should be wearing a mask or not. And then I came to Rhode Island for a weekend, and I never went back. I mean, that's how fast it happened. It just did. So, but I do believe that this is not the last pandemic. I believe that we need to take all of the lessons that we can from this, because this is not going to go away. And there are people in the public health field that have been talking about this for over a decade. A woman named Rory wrote a wonderful book called The Coming Plague in 1995. And you'll see her on most news shows these days because she nailed it. And so I think we need to take these lessons, turn them into policy.
Lynn asks, I'd like to hear if the nurses had any recommendations for us as nurse educators about how we might prepare nurses entering the practice.
Well, I have a lot of recommendations since I've been working in disasters for a number of years. I don't know what all curriculums look like, but there's very, very little that we're teaching nurses. We really are not teaching them. And the thing that's really been interesting to me is since Kim Glassman, who was vice president for nursing for 20 years, came on our faculty, she's got classes she's planning right now. I mean, she is very, very serious about it. And because she knows she had a workforce that wasn't appropriate. And she says, when we were doing Sandy, she said to us, it sounds easy, like, okay, we should teach them how to use med sleds for evacuations. These are these things that you have to take down the steps because the elevators aren't working and stuff. And she said, it's a half an hour for them to go to an in-service that, and they've got other things they're going to do until somebody tells them it's a priority, that they have to do that first. So I have become like, I don't know, a cheerleader for more education about this. There's just no question that we can do a lot better.
Another attendee says, thank you so much for sharing these compelling stories through your research. Do you believe that disaster and safety training will be incorporated into nurse training and education?
I think it has to be. I mean, you can see they're just thrown into the deep end of the pool here. They don't, they really don't have a framework for it. I mean, I actually did have a framework for it, and I'm not sure where it came from. Well, probably because I do all this research in disasters. And certainly public health people are more trained for it. And there's no reason why all health professionals can't be.
There's also a couple of comments. I feel the comments by the nurses were very real. I also feel some of us still haven't had time to decompress. Denise adds, the experiences of these nurses definitely resonate with what we experienced in the hospital setting in Rhode Island. We experienced a significant trauma in our department one weekend, and the next COVID hit, and we never stopped.
Mm. Thank you for that. That's, I'm sorry for your experience, but I'm very happy that you shared that information.
Okay, Karen says, I'm a member of the Massachusetts 1 DMAT team and have responded to national disasters from Hurricane Katrina to Sandy. I am an assistant nurse director in a NICU in Boston. I volunteered to work for a month from April to May in the adult MICUs. Our hospital did have trainings for nurses prior to being redeployed to COVID units.
There are programs, and I know in New York City, the health department offers them. They're kind of like weekend warriors. They go in and they take some stuff, and it's sort of like an extra skill set. I think it needs to be a core skill set myself, but that's how most people I found in nursing who feel confident, and the travel nurses all have that kind of background too.
Excellent. There's no more. There's no more questions.
No more questions. Did you have any other questions that you wanted people to reflect on?
No, I really, I wanted to ask about people's educational experiences, where they were getting trained, where things were coming from, and really wanted to get a sense of how the stories that our participants told resonated with people. And I actually am interested in this last comment, I think reflects it, but are people concerned? Are people, what do you see the future as? What would be the challenges for you if we get yet another bad virus? No one wants to think about it.
Other comments or questions? All right. I would like to thank Dr. Devanter. This is incredibly powerful, and to thank you for sharing your findings, but equally, if not more important, for sharing the voices of these nurses who have to be heard.
They have to.
They have
Absolutely.
to be heard. And thank you. And I thank everybody for joining us. Any final comments?
No, I appreciate the opportunity. This is actually the first time we have publicly talked about what we found in this particular study. There are actually two other studies that are the quantitative is ongoing and stuff. So I really appreciate having an audience to get feedback from. And it's hard to tell, I do worry a little bit that it's kind of a discouraging study, and or story, not a study, but I have worried about that, and that I don't want people to feel helpless. I think it comes through that sometimes people do feel helpless, and I don't think that's a good place for us to have nurses go. I think we need to get our skill sets and push it like I said, it's not going away, and the climate disasters are even rising faster. You know, certainly, how many hurricanes have we had this year? And we're lucky in Rhode Island. We haven't had a bad time since, I think it was Sandy or Irene, yeah. So anyway, so I appreciate everyone for zooming in, and wish you all the best of luck, and hope that you get your curricula in a place where people can really feel more confident.
Thank you. And
You're
thank you
welcome.
for joining us. And hopefully we will see you at the spring distinguished lecture as well. And this concludes our program. Good night.
Good night.